Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I have the pleasure today to be speaking with Dr. Ben Fischer, an internist in a direct primary care practice in Raleigh, North Carolina. Good morning, Dr. Fischer.
Good morning, Larry. Good to be with you.
Good to be with you as well. And do you mind if I call you Ben?
That would be great. Yes, sir.
Great. Thank you, Ben. So could you give us some picture of your background, where you went to school, residency program, and then your early years of practice?
Sure. I was raised a Texan and went to Baylor Medical School in Houston, Texas, which is my hometown. And following medical school, I took a commission in the Navy. They had given me a scholarship at Baylor, and I did my internal medicine residency at the Naval Medical Center in Portsmouth, Virginia. I then did a chief residency year there. Really enjoyed the teaching aspect of my profession, and then spent a couple more years on the West Coast with the Navy in Whidbey Island, and along the way married my wife, who then drew me back after the completion of my Navy obligation to Raleigh, North Carolina. And so we have lived in Raleigh, North Carolina, and raised our family here. And I have practiced for the first 10 or so years I was in town in an internal medicine group practice, private practice, and then in 2016, with my wife's help as my practice manager, we started our own direct primary care practice here in Raleigh that we've been running now for the last 2 years.
And what was it that led you to transition from a traditional insurance-based practice to a direct primary care practice?
I had the good fortune of taking over a practice in Raleigh from a retiring physician who practiced in a very admirable and old school way, and in the sense that he knew his patients well, he was devoted to them and they to him. I stepped into a role where he carefully selected me, found out a lot about me before he chose me for his practice, and then sent a letter to all his patients introducing me, saying who I am, who my family is, and why he chose me, and then he ceded also his nurse of 10 years to me. So I walked into this very personal practice with patients who were for whom I was given a lot of trust by my predecessor, and I stepped into that and thought, this is good and right, and this is something I want to aspire to. I admire the way that my predecessor practiced. The expectations that my patients have of me and that my nurse has of me are the expectations I want to fulfill as a doctor. I want to know these people, and I want to care for them, see them in their difficult times, and know them in their better times. And then over the arc of the next 10 years, I've found that the system of medicine around me was thwarting those ambitions, and I found myself on the board of my practice, and we were continually meeting, never to talk about patients or patient care, but about these quality measures, as they were called, initiatives from corporate and government insurers that micromanaged how we documented, how we did everything, all using the computer as the tool of implementation to have us march down a path that in name was leading us to be better doctors, but I kept finding that it was making me a worse doctor, as it was distracting me from what I thought was my core mission, and to know and care for my patients. And so I, as a member of the board, they got sick of me saying, why are we doing all this? This is not helping. This is making us worse doctors. And then I had heard about direct primary care really my wife handed me an article from the Medical Economics about Brian Forrest, who is a longtime direct primary care practice pioneer here in Apex, North Carolina, which is very close to us. And so over the next year or so, we thought a lot about that and prayed about it and read about it and thought, gosh, I think that is the right way to take us back to where I was trying to go in the first place. And so that was the thought process behind how we jumped into direct primary care.
So I know that for some practices, the transition from traditional to direct primary care can be pretty difficult. Patients may not want that model of payment where they're paying a monthly membership fee. Can you comment on how that transition worked for you?
Sure. It was a scary time. I had to leave my practice because we were a 20 to 30 person group primary care practice, and my partners were not interested in transitioning the whole practice to that model. So I had to leave, and I had no desire to have a fight with my practice because I had no animosity there. My animosity was towards the outside forces that were controlling and shaping us, and I felt I needed to get away from those. So it was a long process of first explaining and talking to my colleagues why I was doing it, sort of at some level trying to talk them into or convince them of what I was doing, but eventually I stopped trying to talk people into it and just said, this is what I feel like I need to do, and how can I do this without harming you all? So we waited until we could find somebody to replace me, and then made concessions in terms of financial concessions that were difficult for us, and then the next step was to convince the patients. My practice allowed me to have a forum. We used the sanctuary of our church to invite people, and had a good several hundred of my patients come out, and I tried to, as best I could, explain to the patients the problems that really I saw and they didn't see. As far as they were concerned, I was doing what they wanted me to do. I was paying attention to them and doing what I felt I was trying to do, but they didn't understand what was happening behind the scenes, and what that demanded of the physician to try to push away from the pressures, the bureaucratic pressures, in order to free up time to pay attention to them, and the patients didn't necessarily realize that was totally unsustainable for the physician, and was not something I could keep doing. So, in other words, they weren't necessarily dissatisfied with my care. So it at that point, so it took some time to I just told them the story a little bit. Here's the forces that are at play, and I'm here to defend the patient-physician relationship, and I want to honor that, and I want to take good care of you folks, and that's why I'm doing this. And I had enough people leap early on. A couple hundred people in the early stages came with me, which was enough to make us financially viable, or kind of break even. And like many other people who've done direct primary care, I'm sure we moved and took out a larger mortgage and assumed we'd be living in debt for a while, so just kind of tried to free up some liquid resources in that way. But fortunately, in retrospect, we really didn't have to go into debt. We had a great facility, a very modestly priced small facility in the back of an historic pharmacy here in Raleigh, which was both affordable and also projected a little bit the ethos of what we were trying to project, old-fashioned and not the same old. And we pretty quickly, within a year of opening, I was at the limit of my patients that Brian Forrest had helped me to project, and also that my nurse and I realized when we were during flu season and whatnot, trying to take care of people, we were sort of at our limit in terms of the surge capacity on busy days to be able to accommodate our patients. So within a year we were full, and then I was casting about looking for a partner after that.
And I understand you found a partner.
I did. I found one of the greatest blessings of my last year. Since doing this has been the partner that I get to share my work with. It's a very this medicine is a very relational business. If you do it in the way I've described, you have close relationships with your patients, and you also, in a direct primary care practice, you have a very close relationship with your colleagues. My nurse and I work very closely together, and so in terms of a partner, I knew that we needed to really share vision and for what we were trying to do, and I found a person who I looked for a doctor who was very well regarded by colleagues and by patients, and I'd heard rumors about a doctor. My partner's name is Zane Lipinski, and I would hear about him from close friends who are specialists that they would receive patients from this primary care doctor, and he was a staunch advocate for his patients, and he really went above and beyond, and so he had a little bit of a lore, this physician, and so I kind of cold called him and said, I think you're the kind of person who's not going to want to keep working in the way that you're working, and you may be a refugee like me, and you may be looking for a way to do something that's truer to your what you perceive your calling to be, and so I managed. Took me about a year. My wife jokes that I courted him longer than I courted her, but I eventually wore him down, and he joined me starting in January of this year, and it's just been a real blessing. Yeah.
My understanding, he's a family physician?
He's a family physician, so his scope of practice is a little different than mine, which, we're still working out those kinks a little bit. I don't take care of little babies and those sort of things, so adult patients is my line as an internist, but I think we're working through that fine, and I've been fortunate, Larry, as you know, I've joked with you a little bit over the last couple of years, as I've gotten the privilege of going to FMEC, Family Medicine Education Consortium meetings to speak about some other work that I've done. I've kind of found I've found this incredible heart in family medicine that I admire, and that I almost feel, not to disparage my internal medicine colleagues, but we tend to be pretty head-centered. There's a fairly cerebral profession, but I think family medicine, from my observations, tends to bring a lot of heart to their practice, and so I was glad to find a family medicine. I wasn't surprised to find myself partnered with a family medicine doc, given what I'd seen at those meetings, and so yeah.
So you've developed a rather unique relationship with your local YMCA. Could you explain what led to that and how that works?
I can. So before I left, maybe about 10 years ago, really pretty early on in my practice here in Raleigh, in my previous office, like all primary care physicians, I would see many patients with chronic illnesses, many of which were preventable: diabetes, type 2 diabetes, hypertension, heart disease, hyperlipidemia, hypertension, all those sort of cardiometabolic problems that have burgeoned and become so much more prevalent with the obesity epidemic in the United States. And so I just would always think, goodness, I can keep prescribing you all these medicines for your long problem list, but your problem list is really only, I'd say you, as speaking in general to a person with that kind of host of problems, I'd say your problem list could be longer. It could really, we could just reduce it down to your unhealthy diet and exercise habits and the consequences of it. So if we could get at that problem, we could eliminate all the other problems. And of course, that's no great insight. Lots of doctors know that, but I realized that preaching at patients didn't do any good. They didn't. Change didn't often happen by that. Change is hard, and so I said, well, I tell you what. How about if I won't tell you what to do. I'll do it with you. How about if we go to the Y together and we'll walk through this journey together. And so I kind of made it up as I went along, but that was the basic notion that we would meet at the Y with a group of patients and exercise together and have classes on diet and exercise. And so over the years it grew and parts were added to it, but the local Y said, sure, you can bring your patients here, and we figured out the legal parts of it and the liability parts of it, worked through some of those details. But in essence, it's a 3-month program where we would have a Y instructor lead us in a weekly exercise program, and I'd have either myself or an invited physician or a dietitian or somebody else give a talk on various relevant health topics. All the disease states I just mentioned, hypertension, and orthopedists talk about arthritis and weight-bearing joints and all those sort of things. And then there'd be a weekly weigh-in, and we'd set some goals as a class. And you usually have about 15 to 20 people. Before I departed from my previous practice, we figured out how to do that with where all the visits were 99213 visits. Just I was meeting them at the Y to treat their hypertension, and it was a counseling visit. So all the requisite coding or documentation that had to go to that. But that made it financially viable in the insurance-based model, which was good and made it possible. But so we've had several, 10 years of 20 to 20-ish patients, maybe 30 to 40 patients a year doing that, and that doesn't mean that 30 to 40 patients a year times 10 years made dramatic changes in their life, but it does mean that some percentage of those made dramatic changes, and it was it's been one of the most gratifying parts of my practice to help people to truly be healthy rather than to be. I tell my patients I'd rather you be well than well medicated. So to help some number of them actually be well has been great, and it partially informed my decision to leave practice, as I realized in doing that sort of work that was a part. Certainly seeing my patients in sickness was also important, but that was a part of what doctors are for, or what value I can bring to patients, and those are things that are not easily. I could do a study on it, but those are not necessarily the metrics-driven things. To help over a long haul walk through a journey like that with a patient. It's I think that's the kind of thing that doctors are for, and that's not the kind of thing that I found. Though I found a way to do it within the system, it wasn't necessarily what I was being driven to do. I was being driven to process people quickly and put them on a statin if they had something, or put them on this or that, to do sort of protocol-driven medicine rather than this kind of intensely relational lifestyle change medicine. And so that's been my work with the Y. It's been great and rewarding. I've loved the partnerships with the Y, which is a wonderful institution. I've also through that developed partnerships with dietitians, with mental health counselors. Of course, because when you find out when you're trying to change people's behavior, you go into it thinking, I'd like to lower your blood sugar, and you wind up talking to them about their marriage and their work and their stressors and the things that prevent them, are either real or perceived barriers to making changes that ultimately would lower blood sugar. So all those interdisciplinary relationships have been rewarding and enriching to my practice and to my patients. So it's kind of taken me out of the silo of just going to the office every day and seeing patient after patient and not getting into not that doesn't have value, but it can get you in a rut. so it helped me stay out of a rut.
So Ben, I would just like to bring things to closure here by offering an observation. You are every bit a family physician, except in your specialty designation, and I would have all family physicians and all general internists learn from you the value of going where your heart leads, and then building the pathways. You are a pioneer, and I really appreciate and have to commend the risk that you've taken and the success that you've had.
Well, I sure appreciate that. I think that in medicine we are privileged to have a calling and not have a job, and our calling is to care for people, and we can fulfill our calling even in this sort of grim seeming time of statistical driven medicine by saying by my fundamental realization was that I could change the circumstances of my practice instead of try to accommodate my practice to adverse circumstances, and we in primary care we don't have a high overhead, and so you can care for people with a low overhead and not incur a lot of out-of-pocket expense for patients while still making a living as a physician, and it's a wonderful path. I would commend it to any of my colleagues who want to practice with both their heart and their mind, which is what the practice of medicine at its best is all about.
Well, thank you very much for spending time with me this morning, and I am when this podcast goes out, I'm hoping that you will inspire others to follow in your path, and we can in general move from what I call a production-oriented healthcare system to a healing-oriented healthcare system, and you are a wonderful role model for people to follow. Thank you very much.
Thank you.